So want to start today, let's start with a clinical case and talking about elevated glucose levels, and you're going to hear the same story, the same themes that NAM had started with. So here we've got elevated glucose levels with a glucose meter. Starts with the story of a 54-year-old female and presented with disoriented, drowsy, unconscious, leading to unconsciousness in about an hour. Checked the glucose with a glucose meter, and it was 187 milligram per deciliter. Her history, diabetic chronic kidney disease. The gal was then taken to the hospital, and on admission, she was totally unconscious, no response to deep pain, etc. Looking at her vitals, you can see the vitals, heart rate, blood pressure, respiratory rate. People were not too concerned with this. They then did a capillary glucose that I will try very hard to remember that. It just rolls off my tongue though. A capillary glucose, and the capillary glucose was very, okay, we're talking 20 milligram per deciliter difference, but it's up there and high enough. What the differential diagnosis for this patient was brainstem CVA, metabolic encephalopathy or uremic encephalopathy. But what they also did was they ordered an MRI, a brain MRI, and the results from this were suggestive of a hypoglycemic encephalopathy. And so they're going like, what the heck? I've got a 187, and this is a huge disconnect. Like, what in the world is going on? Well, at that same time, they had ordered laboratory results, because you don't want to put all your eggs in that one basket of the glucose meter. And what they found was, look at this, a low hematocrit. And building upon what NAM had to say, that hematocrit can profoundly affect the results of certain glucose meters. And in this particular case, it was low. And as NAM pointed out, that low hematocrit, you can cause an overreading of the glucose results. There are other glucose meters that have been reported to be affected by sodium. Now, this patient's sodium isn't an issue, but extremes in sodium have been shown to affect glucose meters. Uric acid, but now the real punchline here is the plasma glucose. My goodness, we're going from a 187 now to a 24. And so the patient, obviously, it's justified why the patient is presenting in the manner in which they are. So what they did was they started their treatment, the dextrose, and within minutes, the patient is regaining consciousness. And discharged home, diagnosis, hypoglycemic encephalopathy. So now this is just yet another example of a clinical case of, my goodness, you're measuring glucose results, or you're measuring glucose with a glucose meter. You are maybe treating a patient based on those results, but you really have to be comfortable and confident with the performance of whatever method you're using for glucose. Be it a glucose meter, be it a blood gas analyzer. We have to be concerned about interferences. As all lab people, we know those interferences will cause bias and a significant inaccuracy that could significantly affect the treatment that patients could receive. So it's something that definitely, I can say, contributes to my hair color. Absolutely. So when we look at the objectives for today, I want to talk about point-of-care testing for glucose in hospitalized patients, discuss the problems that we see because of glucose meter inaccuracy, and then present evidence to support the role for glucose testing and in glycemic management. So why do we use glucose meters in the hospitals? Well, we use glucose meters because We are concerned about identifying really the patients who are high or the patients who are low. Now, NAM gave a very good outline of patients where you're looking at that glycemic variability, the wobbling around, going from high to low, and in the critically ill patients with the tight glycemic controls and being concerned where you've got the patient going from that high and then you're causing them to go to that hypoglycemic, and you want to reduce your number of hypoglycemic events. But in the hospitals, and this is where I'm going to get up on my pediatric or NICU soapbox, and that is we have the other issue in NICU. In NICU, what we need to do is we need to accurately be able to identify our babies who are truly hypoglycemic. And that's going to occur for babies who are within those first couple of days of life. We're all really worried about identifying them. And so last thing we want to do is to miss a baby and overcall a situation, overcall the glucose when the baby is actually truly hypoglycemic. So we've got, those are the two areas that we really, in the hospital, are the areas that we're concerned about with glucose and using glucose meters. I sort of got a little ahead of myself here. So what you can see is that we have, in emergency, you've got the evaluation. We're going to be looking at evaluation, detection of hypoglycemia, et cetera. You've got your various other units. For ICU, of course, NAM addressed that, why we're measuring glucose in the ICU. And I just discussed the issue of measuring glucose in the nurseries. So ultimately, what we're looking at is we want glycemic control. Whatever it is, we want glycemic control. As we know as laboratorians that we have challenges. It doesn't matter what test you're offering. We will have error. And our error, as NAM had pointed out, we've got bias and imprecision errors. And there's errors in everything. But what we note is that over the majority, given my last name, I like to use this line. Since my last name is Lyon, I say it's the lion's share of error, is seen with pre-analytical error. There have been publications to show that 68 to 70% of lab-associated errors occur pre-analytically. So, gosh golly, you know, like that's before we've even got the sample. And so it's a concern. And then, of course, you get the call to the lab and what's going on? Why is this problem from the lab? And you're going, well, hold on, it's not my problem. But, you know, the issue is, let's look at it. And again, I apologize, but I put things in neonatal perspective. Pre-analytics. Question is, when we're looking at a heel poke for a child to collect a specimen for a glucose measurement, should you warm the heel or not? Yes. Oh, thank you. That was really well done. Okay, tell me, why should we warm the heel? Why? Better circulation, absolutely. This is absolutely right, because that is going to give you your best quality sample. And as we all know, that, and NAM put it in, you know, you get a garbage sample, well, gosh golly, you're going to get a garbage result. And when you're looking at, again, I'm back on my pediatric neonatal soapbox, but when we are trying to identify hypoglycemic events in those kids in those first couple of days of life, we got to make sure that the quality of the specimen that we have is going to be the best quality specimen. So pre-analytics, big factor, very big factor when it comes to any lab result. Okay, glucose meters. Lots of different factors that can influence the performance of glucose meters. NAM talked about many of the exogenous factors, glucose, galactose, et cetera. Endogenous factors like hematocrit. We talk environmental factors, altitude, temperature, humidity. So what we have here is, as Nam pointed out before, we've got lots of different compounds that have been reported to interfere with glucose measurements. And they're non-glucose sugars, and I just call them a case of sugar confusion. Can your device actually distinguish these? And so that you're properly identifying glucose. This is just another example of a case with IKU Dextran and IKU Dextran problems. This was a 65-year-old end-stage renal, admitted for renal operation, donor renal operation, past history, coronary artery disease. You can see all the issues. No history, though, of diabetes with this patient. Day of surgery, 2100, patient's alert, awake, everything's good. Neurologically, everything is wonderful. 2:30 in the morning, arrives to the post-anesthesia unit, looking for pain management. They did a finger stick. I had to smile because when I did this slide, I didn't put capillary on. I've changed the term now to finger stick. And so the finger stick was 340, definitely going to get your attention. And at 4:15, they started IV insulin. That's a good enough glucose to be able to get that. Patient's discharged in stable condition. Next day morning, everything seems to be fine. Afternoon, starts to get a little drowsy, increased drowsiness, transferred to ICU, and then hemodialysis was initiated. Unresponsive, basically at 1900, and second day post-operative, they did an MRI and ECG, and they were seeing they had something going on. They were saying a toxic metabolite encephalopathy. At this point, instead of doing a glucose meter measurement, they sent it to the laboratory, and they got 43. So that's consistent with the story that Nam had presented previously. So we've got a huge discrepancy. Well, oh my goodness, they stopped their insulin right away because they thought, yep, we've got a problem. And they started, I should have pointed out, they did start their dextrose at that point. And this slide, what it's showing is just the discrepancies between the point-of-care glucose measurement versus the laboratory's measurement. And interestingly, at the beginning, they used that point-of-care glucose to titrate and get their insulin going. So this is where, again, we can talk about biases, we can talk about correlations, but we really have to be confident about the analytical quality of whatever methods we're going to use to measure glucose, because it can profoundly affect our patients. They figured that the patient had received this number of units of insulin before they recognized that they were using the discrepancy in the glucose results and the problem with the glucose results. So what happened with this patient? Well, actually, patient never recovered from the neurologic issues. So this was a problem. Underwent other treatments, prolonged hospital stay, and this patient was discharged to a care facility. So the impact of, again, and I think we're giving you so many different clinical cases today, but the impact of these clinical cases, and you're thinking, my goodness, we've been measuring glucose since the beginning of time. But the impact and the quality of that glucose measurement, you can't underestimate it. So we've got controversies. There was controversy about the analytic questions about how well did these glucose meters perform. And it was actually in March 2010, the FDA held a public forum to be able to start to discuss these, because the FDA was concerned about the performance of devices in critically ill settings. It was later in 2010, the FDA said that they wanted, for product labeling, they wanted a modification to the product labeling, and they said they wanted it to be saying that not for use in critically ill patients. Well, that didn't last too long, and in November 2010, it was modified. And it was modified to say not evaluated in critically ill patients. And now we've already started to have that discussion. How in the world do I define a critically ill patient? My goodness, that's a challenge in its own right. And just to make things even more complicated, you folks have the FDA and all your agencies. I've got Health Canada. And so I've got that other level of interesting experience. Wow. So since 2010, what's happened? Well, we've got different organizations. Evan's going to talk to you more about this, but the different organizations and what they've done since 2010, they've started to change the analytic performance expectations to say, oh, we weren't what we should have been, but we're looking at bias and imprecision and stuff like that here. So it was in September 2014, there was this glucose meter was actually approved for critically ill patients in that setting. And these were the specimens for which it was approved. In October, just this past year, the FDA has published new guidelines, and Evan is going to talk to you more about that with the new guidelines that the FDA has talked about. I just thought I'd put it in that context. And these are looking at the new FDA guidelines, looking at the self-monitoring for blood glucose, but also the blood glucose monitoring systems. And you can see here that the expectations are tighter for the blood glucose monitoring system. How did that meter get approved? How was FDA clearance achieved by that? This is the fun part. This is the fun part because what happened here was there was definitely, and this was published in Critical Care Medicine, and I would like to acknowledge that NAM is a co-author. I'm a co-author as well as my husband. We're co-authors in this work. Now, what was the kicker here? Well, the kicker is we ended up looking at, well, there are a variety of things. I'll stop, and I'll just go through it in a methodical way. 5 university hospitals, 3 of them, data was collected from 3 hospitals here in the US and 2 in Europe. The patients, Nam in his presentation had mentioned how many studies are done with 100 or 200 patients. Well, this study was actually done with close to 1,700 patients. Glucose measurements, over 1,800 glucose measurements. When we look at the categories of critical care conditions that these patients represented, we had a very healthy number of critical care conditions. Where we're looking at the severeness of illness scores that Nam had also talked about, those were monitored. In this investigation, it was greater than 8,000 compounds that these patients, cumulatively, like all the patients were receiving. So a healthy number of interferences that were investigated. And you can just see the breakdown of the different drug categories that were investigated. So what did we do? What we did was we looked at the typical bias and imprecision. We looked at the correlations that we talked about. We looked at average biases. We calculated sensitivity and specificity values. Did all of that. And like when we all went to school, we're all taught that stuff. And that really is assessing the clinic or the analytical accuracy. But what we had to do is we had to come up with a way to say, what can we use to assess clinical risk? Because honestly, I can talk to my neonatologist in Saskatoon, and I can tell them, oh, did you know that the bias is this, and the imprecision is this, and the total analytical error is this? I have got deer in the headlights look. Like, it's like, and honey, why do I care? You know, I'm happy this makes you happy. But, you know, it really, that's weird that you're all excited about these percentages because it doesn't mean anything clinically to them. And what we need to do is we need to be able to say, what is the clinical risk of using this device in a particular population. So we had to come up with a way to say we were creative and figured this out from scratch, and oh my goodness, but we weren't. We applied other people's very creative thoughts. So what did we do? We've looked at POCT, this guideline. We also looked at Parkes error grids, and I'll talk a bit about those. This was the really fun part, and I'm going to talk more about this, the Monte Carlo simulation modeling for assessing clinical risk. We did sensitivity, specificity, and then we looked to see concordance in the hypoglycemic area. Clinical accuracy, the expectations to see if it was meeting POCT 12A3 expectations. So looking at plus or minus 12 milligram per deciliter for glucose is less than 100 milligram per deciliter, 95.4%. And then if you had values greater than 100, 96.5, definitely meeting the expectations. So from a point to the POCT 12A3. Sensitivity and specificity, looked at those two. And what these graphs are showing is the actual result of the reference method. And let's recognize that these are 5 different reference methods, 5 different hospitals. This isn't just one reference method. These are 5 reference methods versus the glucose performance of the glucose meter. And on the basis of that, we could then calculate sensitivity and specificity. And what we found was that our mean sensitivity was 95.2% and mean specificity 95.8%. Not too bad. Still, this is older-ish analysis. Then we get into the fun part, and that is the simulation modeling. And what I'd like to do is to step back and just talk a little bit in detail about what the simulation modeling does, because we're concerned about clinical risk. When we measure glucose in an ICU patient, in an adult ICU patient, what we're primarily interested in, number one, is they're hypermetabolic, as Nam had mentioned. So we want to say if they have that high glucose, we want to be able to identify them. And clinically, we're going to give them insulin. So we have to have something that is appropriate for directing our insulin and the dose of insulin we're going to give the patient. So one way of assessing clinical risk is to assess errors, potential errors in insulin dosing. And what effect does bias and imprecision have on that? So we used a computer simulation modeling called Monte Carlo simulation modeling. Now, my husband and I did this together, and this has been done for quite some time. It's a mathematical technique, and the people who were the real creative guys getting this started in the whole area of glucose meters are Boyd and Bruns, and this was published back in 2001. They did the initial work. And what they were doing was they were looking at, if I have a glucose meter and that glucose meter has so much bias and so much imprecision, what is its effect on giving too much or too little insulin? Really important stuff, because that's where the rubber hits the road. If I'm giving too much insulin, my goodness, my hypoglycemic rates, I could have a problem. So I need to make sure that my glucose measurement is going to be appropriate. Sorry, I went on too much, and I will stop. I will stop and just say, wow, glucose is so cool. Glucose is it's key. You know, something as simple as glucose, we've known it since the beginning of time, but we've got to be able to measure it. We've got to measure it properly. We've got to accurately and precisely measure it. And the effects that that has on the clinical treatment of our patients can be profound. And with the cool new models that we have with this simulation stuff, and if anybody wants to talk about that, I'd love to share it with you, because we've applied the simulation stuff not just to glucose, We've applied it to INR, point-of-care devices. We're working on it for hemoglobin A1Cs. We're looking at it for creatinine. So we actually had a publication in Clinical Chemistry earlier this year. We applied it to troponins. So this idea of using simulation modeling to be able to assess, but let's recognize, folks, it is a simulation model. But it's at least a start to be able to investigate the clinical risk that this device or this assay can pose to your population. On that note, I thank you so much for your patience.